more complicated procedures, then there'll be some things that we're looking for outside of just light anesthesia. But what we're talking, are you videotaping?
Mm-hmm. Do you mind?
I guess.
And we share as a class, so.
Yeah, I don't know, okay. Whatever. So
are you getting distracted?
No, I'm just trying to think exactly where I was real quick. I'm watching the whole thing. Oh, so the clinical indicators right now of light anesthesia is what we're going to be, I want you guys to do for this first case, right? What is our patient asking from us? So what are some of the things that we're looking for when I say light anesthesia? What's one thing that we can
vital sign changes.
Vital sign changes, tachycardia, sweating,
crying.
That would be a sign of a light anesthetic. And your last anesthetic. Let's talk about that. Tachycardia, hypertension. In our patient that you guys are going to be doing with the lap chole, is he going to be breathing spontaneously, or is he going to be breathing with a mechanical ventilator? Mechanical ventilation, correct. So another sign we would use for the spontaneously breathing anesthetized patient, tachypnea, where it's going to be obscured. So we're not going to see that, but the tachycardia, the hypertension, if we had a BIS monitor, the elevation in the BIS, those are some things that I want you guys to pick up now in the maintenance mode to dose your anesthetic, okay? When I said other signs for maintenance and other complicated procedures, you remember in Barish where we had that funny looking graph, a cartoon if you will, the diagram of the sea of prep. You had the intubation mountain, the sea of prep, incision, etc. So what that's telling you, and what you guys have, it's probably all making sense now, is you do your induction, which is what we've done thus far. And in between that time and the first incision is really a low point. And so I've taught you guys to do your induction, do your left or right sweep, turn your gas up to 2%, go back tape and get ready for the procedure. And as you do so rightly, this patient is going to be really more anesthetized for the amount of stimulation that's going on. So you're going to be fighting things like blood pressure and all of that clinically. And then when surgery comes, we need to make sure that the patient is properly anesthetized for first incision. On incision, we want to make sure that they're adequately deep, right? That's why I have you guys turn the gas on and wait. How do I know when I have enough gas on board?
You look at the end title.
The end title of the agent, right? And how long, as soon as that says, end title says 2.0 for SIVO, is that patient ready for incision?
You want to be a little deeper, right? Incision.
I don't know. Well, I mean, what do you want? You want a MAC?
Don't you want a MAC of 1.5?
That's MAC bar. But what is MAC? What's the definition of MAC?
50% of the patient will be stimulated by
Will not move on surgical incision or surgical stimulation. So I'm okay with MAC. MAC is good. That's why we have MAC, right? Here's what I'm getting at. You guys do your left or right sweep, turn this on, come back, and next thing you know, my end title is 2.0. That patient's not ready yet. Remember the time constants that you've learned in Dr. Toon's class. We at least need to have 4 time constants before that patient is truly at a MAC of gas in their brain, right? Their tissue is at a true MAC. Everything else is still equilibrating. So at that point, that patient will be ready for incision. More advanced procedures that we're going to look at, are they ready for certain physiologic changes? As we get into laparoscopy on Monday, you're going to see certain things that will affect the dynamics of that patient being ready for different procedures and maintenance. Are they volume loaded? Knowing the procedure, reading in Jaffe of your specific procedures going up, making sure that you're ready for those different things. We have enough muscle relaxant, have different things like that. So that's maintenance in a nutshell. We'll practice that right now. When we talked about emergence and emerging the patient, we're essentially landing the airplane that we've taken off in induction. So we're going to reverse everything that we've just done. Now, how long does it take to blow gas off? What have you guys learned about that? You did your volatile anesthetics and pharmacology.
We haven't really discuss about time frame, but we just know this blows off the fastest.
Does blow off the fastest.
And then SIVO and then ISO depending on the duration of the case.
Remember uptake and distribution? Okay. Did you read eagers and uptake and distribution? Yes? Yeah? Okay. So what does eager say? How long does it take? How do we get rid of the gas?
Blow it up.
Okay. So
So ventilation.
you ventilate, but we have redistribution going too, right? So all of our tissues are saturated. So we're gonna have time constants is what I'm getting at, involved in that. We're not just gonna blow off the gas and it magically goes away. I mean, that's how we get rid of the gas, but we're dealing with some time too, right? Here's what I'm getting at. In that emergence, we just do not wait until we hear vicral. And vicral is gonna be telling us that we're gonna get down to the fascial layer, usually when we're closing and we're 5 or 10 minutes away. If that's when we start to wake this patient up, we're gonna be behind the 8 ball. Okay, we need to start getting that patient emerging quicker, hence knowing that surgery. It's going to take at least 4 time constants to blow that gas off, if not more. You know, the fatter our patients are, remember your different vessel groups, right? Your vessel-rich group, muscle-rich group, etc. When we talk about those different compartments, you know your fat is saturated with a volatile anesthetic. It's going to take a while for that to leach out, right, and redistribute. So what I like to say is at least, instead of 4 time constants to equilibrate in the brain, I like to say at least 6 time constants. Roughly 20 minutes to really adequately blow off the volatile anesthetic. So that when I wake this patient up, I'm not dealing with any residual gas. Which residual gas can automatically make them have depressed respiratory rate, depressed ventilations. And so they're going to be holding on to that gas because they can't blow it off. Does that make sense? So in that emergent stage that you're doing, you're getting most of that gas blown off. You can do it with a mechanical ventilator, and as they start to wake up, what would you expect to see in the anesthetized patient?
See Karate notch.
Okay?
The twitches come back.
Okay? And exactly, and that's what I was getting at, is that in the Karate notch, we reverse them and all that, but even if we give the reversal, and we'll talk about that in more detail in a second, but even as we give the reversal, the patient is not going to breathe usually because there's not a lot of stimulation towards waking up, right? Just stitching. We've reversed them. They have 4 out of 4 with sustained tetany on the neuromuscular stimulator, and the patient's still not breathing. Okay, so we want to start to wake them up. As we blow that gas off, as we build that end-tidal CO2 together, those are going to get that patient stimulating their own, they're going to initiate their own respirations. Eventually, then we're going to see on the monitor, we want to call it a Curare notch, but their own spontaneously ventilations, okay? And that's something we want to start getting sooner than later, because then we can titrate in narcotics if needed. Then we can actually get them to a point that I know, okay, they're starting to maintain they're getting to the point to where they can maintain their own airway. We can now definitively take out a perfectly good airway, and the patient still be safe, okay? What are other things that you would think about giving to the patient as you're waking them up? What's a common side effect of anesthesia, common complaint?
For
PONV.
nausea and vomiting.
PONV.
Yeah.
So we want to think about that as you're doing your plans. What do you like to get for PONV? What have you read? What have you done in the unit?
Zofran.
Ondansetron.
What's that?
Zofran.
Zofran. What else? Is that it? Just Zofran?
Breakland.
Is Reglan an antiemetic?
No, it's more prokinetic.
It's prokinetic. Right? You see a lot of people give it as an antiemetic, but
Yes.
it's not really an antiemetic. What else? What did you say?
Phenergan?
Yeah. Phenergan's kind of like a rescue. Hopefully not. Right. What are you worried about with Phenergan?
The problem
Really about 2 things, really. First of all is, do I have a patent IV, tissue necrosis? That's an extremely bad side effect. Second thing is that it's a kind of a sedative drug. This patient I'm trying to wake up, I don't know if I really want to give them all kinds of sedatives. As I pull this perfectly good airway, then they have a respiratory event. So another drug, you guys heard of dexamethasone or Decadron? That's a great antiemetic. So I want you to think, are we going to give, what is Decadron? What kind of drug is Decadron?
Steroid.
How do steroids work? And where do they work? No, I'm going to put this on the exam. Where do steroids work? What's that little thing in the middle of a cell called?
They work
The
at the plasma.
nucleus?
Direct
They work in the
gene.
nucleus, right? So does that happen fast or slow?
Slow.
So is it going to benefit us to get Decadron as we're emerging a patient?
No.
No, but we're worried about PONV, so when are you going to give Decadron? At the beginning, right after induction, right after that tube is taped, right? Because I'm thinking about it. Do you like to give Decadron to an awake patient? Probably not, since I'm asking. But why? Why? Probably. You'll give it, but you'll give it and you'll do it one time probably to an awake patient. You'll probably never do it again. It actually creates intense perineal itching, or in females we've noticed even weirder type of feelings in their nether regions. Okay, so you will not give this to an awake patient, but it needs to be given up front, early in the procedure. Okay, so that it can work towards the end of the procedure. So you think about that. What are other things that we think about? So we talked about respirations, getting gas off to where they can maintain their airway and wake up. Talked about PONV. What are other things we're worried about or concerned about in this whole anesthetic?
Pain afterwards.
Pain. Excellent. What's going to be your indicator for pain?
Tachycardia.
Tachycardia. Sure.
Hypertension.
Hypertension. Sure. Think about emerging this patient. Think about respirations and all that. What's your most sensitive indicator?
Respiration.
Respirations. And we've already said that we're getting this patient back breathing. We've reversed the patient. Okay. We have got them to initiate their own breath in their tachypnic. So you're going to watch this patient as the gas blowing off. You want to worry about a couple things. Are they in stage 2? And how would you differentiate respirations from being pain-related versus stage 2? Knowing what you know from my class. Knowing that I went over Goodell's stages of anesthesia 2 times now.
Irregular.
Aha! I'll be damned. Maybe there's a reason I put this here. Absolutely. So if they're tachypnic in a regular fashion, is it stage 2?
Yes.
Bullshit. No.
No.
It's a regular. It's if their respirations are regular.
Then
That's
it's not
tachypnic.
stage 2.
It is not stage 2.
Yeah.
It is some other etiology, which we know would be pain.
Right.
So what would you do for that? Treat the pain.
Yeah.
Right? If they are tachypnic in a very irregular fashion, irregular can just be 1, 2, 3, breath, stop, or whatever. Breath holding, small breath, big breath. Those are your irregulars. Breath holding is something that we see a lot. Then that would warrant further indication for us to look and investigate this. So pain, nausea and vomiting, maintaining their own airway, reversed. Anything else you worry about? An emergent stage.
Hypotension, maybe possible.
Okay, so vital signs, but those are the biggies right there. Okay. We talk about emerging. All the stuff that we have out here on the table, we're going to use. Stuff we probably already used before. So that oral airway we used to mask in the beginning, you're going to want to put that oral airway in before the patient's fully awake. Definitely before that tube comes out. Okay. I prefer to have that in as we're emerging the patient before I give my antagonist for the muscle relaxant. Why?
Because you want to get it in there before they can move.
Okay. Why? That's good. That's deduction.
Yeah, I mean,
But there's a reason behind the deduction. I mean,
You see,
have you ever had, well, not really bronchospasm. Would a muscle relaxant work for a bronchospasm? No.
to prevent obstruction.
Have you ever had a really strong individual in the ICU, a younger patient, awake that is intubated? What did they do? They bit the tube. How did that work out?
Oh, you get to a negative pulmonary.
They get negative pulmonary pressure. Yeah.
I see.
And they can bite the tube and not get oxygen. Don't get oxygen to the brain. I believe, if I remember right, that was bad. Right? So we want to get oxygen to the brain. So put that bite block in before they're awake, before you have reversed the muscle relaxant, so that they don't bite that tube. Suction the oropharynx. Do everything we just talked about. Should be good to go. Extubation. You guys are going to learn to do an awake extubation and practice that way. As textbook is the most common way to extubate a patient. A lot like you did in the ICU. The patient is awake, telling us that they can protect their own airway. that their protective reflexes against aspiration and whatnot are there. Patient is awake. How do we know that the patient's awake? What are some things that we do clinically that we can see? Shock them? No? No. Do not shock an awake patient. That's battery. What are some things that we can do to an awake patient to make sure that they're truly awake?
Do a 5-second head lift.
Okay, see if they can avoid. In 5-second head lift, they have to be obeying commands. So that's what we're looking for, obeying commands.
Hand grip.
You can do hand grip, but have you ever had a brain dead patient do this? I have. And even this, you'll say, give me thumbs up and stuff, can be inconclusive. It's up to you. See if they're obeying commands. Lift your head up. When you start talking to them and you see that they kind of look at you, etc., they start coughing and bucking around the tube, that's a sign that they're pretty much awake. And again, lifting that head up, okay? At that point, we know that they're awake. We know that we can extubate the patient. Imperative, deflate the cuff. Imperative, make sure you suction one more time, keeping that oral airway in. Imperative, when you pull this tape off, take out the cuff, positive pressure, and how do I extubate?
Make sure that patient takes a deep breath first.
Full inspiration. After full inspiration, as they start to exhale, I'm going to do one solid movement of pulling the tube out when I'm squeezing the bag. Okay? And that is doing what? Why am I doing that? So any of the secretions, anything in the mouth or subglottic secretions, I blow past the cords. My whole goal for that positive pressure is to blow anything away from the vocal cords as I can. The vocal cords, why am I worried about the vocal cords? Just because I'm bored?
You don't want to have a spasm,
What kind of
irritants, laryngeal spasm.
Laryngeal spasm, exactly. So I want to blow those back. The vocal cord is very sensitive to that. So I extubate the patient. I should have had the whole class in here. Oh well, I'll say this 3 times today. So there you go. You can just share it on YouTube. So I extubate the patient, remove the tube, making sure I'm not getting a mess. I'm going to have my, hopefully this face mask is over here close, but I'm going to immediately place this on the patient. I'm not going to extubate him right now. But I'll immediately put the mask back on him. And I'm going to be looking, what's my gold standard for ventilation? So I'm going to immediately do this here. I'm going to take this pressure off, holding a good seal, looking for chest rise and fall, fogging and misting, but number 1 is going to be my end-tidal CO2 tracing, making sure that the patient's moving air. If the patient's not moving air, the first thing I'm going to do is make sure I have a better seal. Very quickly though, I'm not going to wait 5 or 10 seconds. It takes negative pressure pulmonary edema can be a catastrophic emergency. It can happen in one breath to your younger patients. So I'm going to look, and if I start to see chest excursion, no fogging, nothing up here, the patient's obstructed. Hopefully, probably not a negative pressure pulmonary edema, but I need to get over here, do a jaw thrust, hold a good seal, and see if something's going on. If that doesn't work, my next course of action, add some positive pressure, 20 probably. Hold a good mass seal. Usually positive. If there were laryngospasms, probably, who knows what it is, but I have an oral airway in, so I hopefully have the tongue out of the way. Should be able to move air. So I do a chin lift right here, as I'm holding a good seal with positive pressure. If there's a laryngospasm, I should be able to break it. Okay? Did I tell you guys about the laryngospasm notch? Did I cover that yet?
No.
Look it up. In 1990, anesthesiology, or Journal of Anesthesiology by, starts with the name L. Lance? I think it's Lance. Anyways, article, look up laryngospasm notch. Basically, remember your pressure point back here behind your jaw? So there's a nerve bundle that, if you push in there, it also controls your nerves that are responsible for causing a laryngospasm. So what I do frequently, I use this all the time. Knock on wood, have not had to give sucks for laryngospasm. But positive pressure, both fingers are back here in the, I'm drawing a blank, what is this?
The angle.
Angle of the mandible, yeah. The angle of the mandible, right underneath where that nerve bundle is. And I push in there and I pull that chest, pull that chin out, elevate the chin. And you can see that's a lot of pressure. But as I displace that, you'll break a laryngospasm, okay? And how will I know that laryngospasm is broke? Clinical sign. End-tidal CO2, fogging and misting in the mask. Audible sounds of respirations, okay? And as I do that, and sometimes, I'm not gonna lie, if I have a laryngospasm, I'll turn this pressure up to 70. I've done it. But I'm very mindful, as soon as that laryngospasm is broke, I have end-tidal CO2, I start to see and hear respirations, then I'm gonna take this back down to 20 because I don't want to inflate the stomach, right? Making sure that that breath is going. As soon as I have a stab, and laryngospasm or not, I'm over here watching, making sure that the patient is spontaneously ventilating. As soon as I'm sure that he's ventilating, taking this off, I'm grabbing my face mask with my McGills. I put the McGills up after I grab them. No, don't grab the McGills. Put on a face mask. Hook up to some auxiliary oxygen. I want a lot of oxygen or a little bit of oxygen? A lot? A lot? A lot?
The middle?
The minimum. Why did you say the minimum?
I said middle.
Everybody feels. No, the minimal amount. Why would I want the minimal amount of oxygen?
To see where his baseline
Bingo.
rests.
Oxygen is a drug, and if I have to supplement with the copious amount of oxygen to get him barely at 90, 91%, and then I'm going to leave the operating room and travel, and sometimes your PACU is going to be a long ways away, and you just have an oxygen tank, usually not even an ambu bag. Probably not a good idea if he's on 60, 70% of FI. No, it's not a good idea. If he can be on 2 liters of air, on no air, and he's holding 95, 96%, then I'm confident that this patient's okay. Does that make sense?
Mm-hmm.
So think about that. Don't cheat yourself, and you'll do it, and you'll learn. But this is the least amount that he can tolerate there. And again, I'm assessing it. After I do that in the sequence, and I don't want you to do this any more than what I just showed you right here, of extubation and washing him. This is the immediate post-op in the operating room of your patient's recovery. What you would be doing next would be grabbing your IVs. Okay, getting the patient ready to go, getting all of your drugs that are controlled, taking those with you, transferring to the gurney. Again, always watching your patient. Last thing you're going to take off would be the pulse ox. All the other monitors can come off. That pulse ox is the last thing to come off. Because of what am I doing? I'm allowing this patient to equilibrate with 2 liters of air, or of oxygen, to see how they're tolerating it. And then I'm confident that I can take this patient. If something happens, I can handle it on the way there. Does that make sense? Folks, that's it. That's maintenance, that's emergence, that's extubation. Seems pretty simple, right? The emergence extubation would be about the hardest thing that you learn in all this, okay? And it's really an art. You'll get it. Questions?
Would you have like a sheet, like a summary, like the one we had for induction? Because there's no like a guide sheet that you have, like an instruction regarding emergence and extubation.
I don't have one, but I can create one. Would you like one created? I can.
Yeah, just so we can have the steps.
Okay.
So
So let me
we only
email
have,
it.
Not that one, the other one.
I know, we only have
Just so that we can, there's a guide when we're practicing on our own.
Sure.
Yeah.
Great idea. POA1. You want sheets. I'm going to put
Step by step guide.
Maintenance, emergence, extubation. Is that what you want?
yeah.
What else you want?
The answers are fine. Are those on there too?
Anything else? How about I just give you the final?
That's fine.
You proofread it for me.
Yeah.
Tell me how I did. I wrote your final, or sorry, I wrote your exam 3 last night. 50 questions. It's good, right? They're worth more. All right, who would like to